You cannot improve what you cannot measure. So let's make mental toughness measurable. 3 components, each of which you can actually assess in yourself this week. I'm Dr. Padda. This is the rebuilding video. Component 1, tolerance. The length of your fuse. Tolerance is the number of hardships or the length of time you can endure before a behavior change occurs. It is not about ignoring pain or pretending difficulty doesn't exist. I want to be clear about that because the phrase mental toughness gets used to mean suppression, and suppression is not what this is. Tolerance is how long you maintain your intended behavior before disruption takes hold. How many triggers can you absorb before you deviate from your goals? How long can you stay on course under fire? Notice that this is measurable. You can count it, and measuring your current baseline is the first practical step to improving it. Because I need to be tougher is not actionable, while I currently deviate after the second trigger is. Once a trigger passes your tolerance threshold, 2 more things become measurable: how far you fall and how fast you get back up. Fortitude is the intensity of behavior change once the threshold is crossed. How far do you deviate from baseline? A high fortitude person shows a small, contained deviation even when genuinely triggered. They're not unaffected. The effect is bounded. Adaptability is the speed of recovery back to functional baseline. How quickly do you return to intended behavior? Slow recovery means longer periods of impaired functioning. And if triggers arrive faster than you recover, you never reach baseline at all. Then there's the failure mode, mental brittleness. Brittleness is staying down for extended periods after a trigger or never returning to your prior baseline, settling permanently into a worse behavioral state. 3 numbers. How long before you break, how far you fall, how fast you return, every one of them trainable. Now the formal instrument, the PTSD checklist for DSM-5, the PCL-5D, is a validated 20-item self-report measure. It reduces lived experience to objective integers, which sounds cold and is in fact liberating. The total severity range is 0 to 80. A score in the 31 to 33 range indicates probable PTSD. For tracking treatment, a change of 5 to 10 points represents reliable change, meaning the change is real and not measurement noise. A change of 10 to 20 points represents clinically significant change. I use your PCL-5 score as a certificate of impairment, a baseline from which measurable improvement becomes the target. Here's why this matters more than it sounds. Without a number, recovery is judged on how you feel today, and how you feel today is heavily influenced by whether you slept. With a number, you can be having a bad week and still see that you've dropped 14 points since March. Data outlasts mood. Now, what may be the single most important predictor, and it is not what most people expect? Event centrality is the degree to which you perceive a traumatic event as a defining central part of your identity and life story. High centrality means the event has become the lens through which every other experience gets filtered. Research consistently shows that event centrality is often a better predictor of long-term distress than the objective severity of what happened. Read that again. How central the event is to your identity predicts your suffering better than how bad the event was. A core goal of treatment is reducing that centrality signal. And I want to be precise about what that does and does not mean, because this is easy to hear as an insult. It does not mean minimizing what happened. It does not mean it wasn't important. It means restoring a broader, more balanced sense of identity. So the event is one chapter in your story rather than the title of the book. The event is not what broke you. The story built around it, and whether you placed it at the center of who you are, is what determines long-term suffering. So what does effective treatment actually do? 2 mechanisms. Habituation. When a feared stimulus is encountered repeatedly in a genuinely safe environment, the physiological response declines, naturally and predictably. The nervous system learns through direct experience that the alarm is a false positive. Note the word genuinely. Exposure in an unsafe environment doesn't produce habituation, it produces more trauma. The safety has to be real, inhibitory learning. New safety memories are created that do not erase the original fear memory, but actively compete with it and suppress its behavioral expression. The new memory says, this cue is safe now. Over time, with enough repetitions, the safety memory wins. That second mechanism explains something patients need to hear. You do not have to delete the memory to recover. It's still going to be there. It simply stops driving the behavior. Therapy is not talking through feelings indefinitely. It's structured, technical retraining of neural pathways so that threatening cues get relearned as safe. Which brings me to EMDR, eye movement desensitization and reprocessing. I want to separate two questions that usually get blurred. Does it work, and do we know why? On the first, yes, EMDR has substantial trial evidence and is recommended in major clinical practice guidelines for PTSD. That part is settled. On the second, be appropriately skeptical, including of what I'm about to describe. The adaptive information processing model proposes that psychological distress is rooted in unprocessed memories stored in a fragmented, state-specific form, never integrated into the brain's broader knowledge network, so they stay raw, reactive, and present tense. EMDR is proposed to facilitate transfer of traumatic memories from the reactive episodic system into the organized semantic system, converting "this is happening to me now" into "this is something that happened in the past." Alternating bilateral stimulation is thought to increase attentional flexibility, inhibit amygdala reactivity, and create an enhanced learning state. That's the theory, and it is a theory. The mechanism remains genuinely contested among researchers, which is fine. We used aspirin for 70 years before we understood prostaglandins. Efficacy and mechanism are separate questions, and only one of them has to be settled before you benefit. So here is where this ends. Your experience was deeply personal. Your recovery is a technical procedure. Those two statements are not in conflict. The second is how you honor the first. You are no longer a victim of a diagnosis. You are a technician managing a signal. 3 commitments from our side: we fix the terrain, addressing the underlying metabolic and nervous system dysregulation, not just surface symptoms. We measure the signal. Recovery is outcome-focused and tracked with objective metrics, not impressions. And we recalibrate the system. Every intervention designed to restore your nervous system's own capacity to self-regulate and to learn safety. That last one is the goal, not a nervous system I control, a nervous system that regulates itself again. If you're carrying chronic pain and a trauma history, they are almost certainly connected, and treating either one alone will underperform. We treat them as one problem because physiologically, that's what they are. If you are in crisis, call or text 988, the Suicide and Crisis Lifeline, or go to your nearest emergency department. Padda Institute Center for Interventional Pain Management, 4477 Woodson Road, Suite 100, St. Louis, Missouri, 63134A, next to Lambert International Airport. Also at 12174 Natural Bridge Road, Bridgeton. Call 314-481-5000 or text 314-886-5902. This is educational content, not medical advice, and not a substitute for evaluation and treatment by a qualified clinician.